puncture headache. It is also known as meningeal puncture headache. It is a relatively common complication of neuraxial anesthesia. Was first recognized by August Baer in August 16, 1898. It presents as a postural headache following therapeutic or diagnostic interventions of epidural or spinal space. Incidence is usually 36% following lumbar puncture, 10% following spinal anesthesia, usually 81% following epidural anesthesia. Pathophysiology, it is usually caused by persistent CSF leak into epidural space via tear in the meninges. Normally, CSF is produced in the choroid plexus at a rate of 20 ml per hour. Total volume is around 150 to 200 ml. Loss of more than 10% CSF volume can lead to PDPH. If more than 10 ml per hour of CSF leak is there, it is a high risk of PDPH. Pathophysiology, CSF loss leads to reduction in intracranial pressure, which leads to loss of intracranial supports, leading to staggering of brain, results in traction and pressure on the pain-sensitive structures within the cranium, which results in headache. It also causes compensatory adenosine-mediated cerebral vasodilatation, which leads to due to decreased intracranial CSF. Clinical features: onset is usually often delayed, but within 12 to 48 hours, but not more than 5 days following meningeal puncture. It is usually symmetrical and bilateral and postural in nature. The headache worsens within 15 minutes on sitting or standing and is usually improves within 15 minutes after lying down. The distribution is usually frontal and occipital, 25% frontal and 27% occipital. It is thrombing, dilating, and pressure type in nature. It is associated with at least any one of the following symptoms, namely nausea, vomiting, neck stiffness, photophobia, and tinnitus. Risk factors include it is usually common in young age people around 20 to 40 years and in non-pregnant females. It's also common in previous history of PDPH following spinal anesthesia and in low BMI pregnant patients. Prevention, it is use the help of proper hydration, use of thin bore spinal needle or pencil point needles. Keep the bevel parallel to the longitudinal axis, and proper hydration can prevent it. Management, most PDH resolves spontaneously. The supportive measures like reassurance, psychological support can decrease the symptoms. Pharmacological management like methylxanthines, caffeine, 500 mg OD can be given. Serotonin antagonists, ergot alkaloids, and corticotropin, steroids, and anticonvulsants can be given. In case of invasive management, epidural blood patch. It is a gold standard treatment for PDPH. It stops further CSF loss by formation of clot over the defect in the meninges as well as tamponade effect with scapular displacement of CSF. The epidural blood patch procedure includes written consent should be obtained, should establish a large bore IV access, position the patient for epidural needle placement, lateral decubitus or sitting position. Under sterile aseptic precaution, place the epidural needle into the epidural space. Collect 20 ml of fresh autologous venous blood using a sterile technique. Without delay, sterility should inject the blood through the epidural needle until the patient reports fullness or discomfort in the back. Maintain the patient in the recommend position for 1 to 2 hours to allow clot organization and regeneration of CSF. In case of pediatric young children, the blood volume is around 0.2 to 0.3 ml per kg. In coagulopathy, sepsis, fever, infections. Others like epidural saline and epidural morphine can also be used. Recently, sphenopalatine ganglion block was also used, which blocks the parasympathetic induced cerebral vasodilation.
Finished?
Yes, sir.
Abhirami, your answers are
Yes, sir.
over? Very good. Okay. Right. You said that the leakage of CSF is the cause for what happens when the CSF leaks 10 ml per hour?
The pressure will decreases.
Pressure in the spinal CSF column. Okay, CSF is divided into cranial CSF and spinal CSF. What is the purpose of spinal CSF?
Maintain the pressure.
To decrease the
Ah,
buoyancy, protective buoyancy effect, sir.
Cushioning effect.
so spinal CSF pressure should be higher than the cranial CSF or less than the cranial CSF?
Higher than the king.
Higher than.
Higher than. Then only it can support, isn't it? So when there is a leakage of CSF from the spinal canal and the pressure in the spinal CSF drops, what happens to the cranial structures?
Traction of
Heavy.
the intracranial structures, sir.
There is a
Traction.
Traction of it.
traction. Weight of the brain acts on the covering meninges and the blood
Yes.
vessels, isn't it? And that
Yes,
is
sir.
the main reason for the pain. So what
Yes, sir.
nerve supply? What is the nerve supply area which causes the pain? Frontal, occipital, neck, all these areas.
Frontal.
Hmm.
Ophthalmic branch of trigeminal nerve causes frontal head pain.
Okay, good.
Cranial nerve 9 and 10 cause occipital pain.
Okay.
Cervical
about-
C1 to C3 may cause neck and shoulder pain.
Neck and control pain. Did you mention that in your answer?
Sir.
Okay, that also has to be included. That comes under part of the pathophysiology. Okay, so that also should be included. How the patient experiences pain, and classically the diagnosis is made by the patient complaining of pain when sitting up or obtaining the erect posture from the recumbent posture. When he is lying down, he does not have the pain. But once they
Yes,
get up, they say they have the pain. That is the classical description of post-dural puncture headache. Is there any other terminology suggested for this?
Headache.
Is there any recent terminology to describe this pain instead of calling it as post-dural puncture headache? Is there any new terminology? You are not aware, okay?
No,
Right.
sir.
Okay, good.